Hi, I am Dr. Selvaraj, your surgical educator from Coimbatore, India. Welcome back to my series of surgical teaching videocasts. These are meant for medical students, surgical trainees, and junior surgeons from all over the world. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. In this video today, I am going to discuss 10 more MCQs on one of the causes for obstructive jaundice, that is periampullary carcinoma. So you all know the importance of MCQ. These are all used worldwide, both in your qualifying as well as in competitive medical entrance exam. So I think I need not emphasize you the importance of MCQs. These series of MCQ videos will give you a systematic way of revising the whole spectrum of general surgery, topic by topic. Before going to discuss the 10 MCQs, I want you to watch the video on periampullary carcinoma. The all 10 MCQs are based on this video. You can pause this video, click this link, watch that image-based question on periampullary carcinoma, and then come back here, and then you can start, watching these 10 MCQs on periampullary carcinoma. So MCQ number 1, a 62-year-old man present with painless intermittent jaundice, dark urine, pale stools, pruritus, and recent weight loss. MRCP shows dilated CBD as well as pancreatic duct, that is the dual duct sign or double duct sign. What is the most likely diagnosis? A. Choledacholithiasis. B. Head of the pancreas carcinoma. C. Periampullary carcinoma. And D. Bladder carcinoma. Of course, the correct answer is periampullary carcinoma because patient presented with painless intermittent jaundice. Periampullary carcinoma causes early obstruction to the ampulla and it is causing painless intermittent jaundice. Whereas if it is choledacholithiasis, it will be painful intermittent jaundice. Plus the double duct sign also is present. That will be present in CA head of the pancreas also. So that is why it is periampullary carcinoma. B is very close. Head of the pancreas carcinoma is very close, but pancreatic cancer typically present later with weight loss and back pain, and so progressive jaundice, not intermittent jaundice. That is the main difference. And choledacholithiasis causes usually, I told you already, painful intermittent jaundice. And gallbladder cancer causes jaundice late and usually present with pain, painful jaundice only. Coming to MCQ number 2, a 58-year-old woman present with obstructive jaundice. Endoscopy revealed an ulcerative mass at the ampulla of Vetter. Which investigation confirms the diagnosis? Whenever we are asking confirm, you have to talk about biopsy. So A, ERCP with breast cytology. B, endoscopic biopsy of the lesion. C, CT scan. D, MRCP. Of course, the correct answer is B, endoscopic biopsy. Explanation, biopsy gives the definitive diagnosis, the histology. A, breast cytology has low sensitivity, that is not confirmatory. C is CT scan used for staging and not for confirmation of the diagnosis. MRCP defines the anatomy but not the tissue diagnosis. Coming to MCQ number 3, a 55-year-old man with periampullary carcinoma is assessed for resectability or staging. CT shows a tumor localized to ampulla, that is the triphasic CT, triphasic CECT. Tumor localized to the ampulla, no vascular invasion or metastasis. What is the appropriate treatment? A. Palliative stenting. B. Whipple's procedure or pancreaticoduodenectomy. C. Local excision. And D. Chemotherapy. Of course, the correct answer is B. Whipple's procedure. Whipple is curative for resectable periampullary tumors. Because CT, it is localized tumor with no vascular invasion or distal metastasis. That is resectable tumor. So the correct answer is only Whipple's procedure. Palliative stenting only for unresectable cases, we use palliative stenting. Local excision only for benign ampullary adenomas. And chemotherapy is only adjuvant and that is not the primary therapy. Coming to MCQ number 4, a patient present with obstructive jaundice. Lab tests show elevated bilirubin but normal CA19-9. CT shows an ampullary mass. What is the implication of normal CA19-9? A. Rules out cancer. B. Suggests benign disease. C. Does not exclude cancer. Early stage tumors may have normal CA19-9 levels. D. It indicates cholangitis. Correct answer is of course C. It does not exclude cancer because in the early stages, it may be CA19-9 level will be normal actually. Explanation, CA19-9 may be normal in early periampullary cancers. A and B, that rules out cancer and suggests benign, both are incorrect. Marker cannot rule out malignancy. So it is not diagnostic. We told all tumor markers are not diagnostic. And D, CA19-9 may rise in cholangitis, but it is not diagnostic. Coming to MCQ number 5, 68-year-old man with periampullary cancer has persistent jaundice and pruritus. Surgery is planned in a week. What pre-op step improves the condition? A. Broad spectrum antibiotic. B. Percutaneous biliary drainage. C. ERCP with biliary stent placement. D. Intravenous nutrition like TPN. The correct answer is of course D. Intravenous nutrition like TPN. Explanation, the pre-op nutritional improvement improves the overall surgical outcome. B is the percutaneous biliary drainage is alternative if ERCP fails. It is more invasive. Broad spectrum antibiotic not indicated unless infection present. And ERCP with biliary stent placement not done nowadays because of fear of perioperative infection because of the indwelling stent there. So nowadays we are not doing this ERCP with biliary stent pre-op biliary stent placement. We are not doing because of fear of infection, pre-op infection. Coming to MCQ number 6, a patient with inoperable periampullary carcinoma develops recurrent cholangitis. What is the cause? It is already inoperable or unresectable. So A, gallbladder perforation. B, stent blockage after ERCP drainage. C, liver abscess formation. D, acute pancreatitis. The correct answer is B, stent blockage after ERCP drainage because it is already inoperable. So to relieve the jaundice, you can put a stent and that stent has got blocked and that is why this patient is developing recurrent cholangitis. Stents often become blocked by tumor tissue or sludge, eventually resulting in cholangitis. A and C, that is gallbladder perforation and liver abscess, are very rare in this setting. Acute pancreatitis is unrelated unless ERCP induced, but not the usual cause. Coming to MCQ 7, a patient with resected periampullary carcinoma, that is T2, N1 and M0, is seen postoperatively. What is the next best step? A. Observation only. B. Radiotherapy. C. Adjuvant chemotherapy, gemcitabine based chemotherapy. And D. Repeat biopsy. Of course, the correct answer is C. Adjuvant chemotherapy. Explanation: the node positive disease benefits from adjuvant chemotherapy. Observation only is inadequate, radiotherapy not routinely used, and repeat biopsy is unnecessary after curative resection. Coming to MCQ number 8, 61-year-old patient present with painless jaundice and iron deficiency anemia. Endoscopy reveals a friable mass in the second part of the duodenum near the ampulla. What is the likely diagnosis? A. Duodenal adenoma. B. Ampullary carcinoma with duodenal extension. C. Pancreatic head mass. D. Choledochal cyst. The correct answer is B. Ampullary carcinoma with duodenal extension. Ampullary carcinoma may ulcerate and bleed that can result in anemia. A. That is duodenal adenoma do not usually present with jaundice. C is pancreatic head mass usually does not ulcerate into duodenum in the early stage. Choledochal cyst is a congenital problem. It presents in childhood or it is a pediatric disease, or choledochal cyst is very common in pediatric age group. Coming to MCQ number 9, which of the following tumors is included in periampullary carcinoma? A. Gallbladder carcinoma. B. Pancreatic head carcinoma. C. Ampullary carcinoma. And D. Both B and C. Of course, the correct answer is D. Both B and C. Explanation: periampullary cancers include tumors within 2 cm of the ampulla, that includes pancreatic head, ampulla, distal CBD, and duodenum, the periampullary region. A is not periampullary, that is gallbladder carcinoma is not a periampullary cancer. Coming to MCQ number 10, which is the most common histological type of periampullary carcinoma? A. Squamous cell carcinoma. B. Adenocarcinoma. C. Neuroendocrine carcinoma. And D. Lymphoma. Of course, the correct answer is B. Adenocarcinoma. Adenocarcinoma accounts for more than 90% of periampullary cancers. A, C, and D are very rare variants. This is not common in periampullary carcinomas. So these are the reference books. See, the first two books are problem-oriented books. Hunt and Marshall's Clinical Problem, Clinical Surgery Made Easy by Mohan D. Silva. These two books are problem-oriented books in surgery. Only very few books are there. And all other books are discussing case-based scenarios, which are very useful because nowadays almost more than 80% of your MCQ questions in your all exams will be only case-based questions. Case scenario, or what they are calling it as clinical scenario-based question only they are going to ask. They are not going to ask just a recall question which can be answered by those who mug up everything and they can answer. So you have to think and answer. That is the idea. That is why nowadays they are asking only case-based questions. Okay, in this, course, you are seeing everything is case-based only. So 100 cases in surgery, case files in surgery, clinical scenarios in surgery. Excellent book, this one. Surgery, a case-based clinical review. So everything is case-based only. And this link I have given, I have talked about all the books which are available for you to become a master surgeon. Please click this link and watch what are the books you need to become a master surgeon. I have included reference books also. So not just Bailey and Love, Sebastian and Schwartz. There are so many excellent books beyond these three books. But unfortunately, everybody is talking only about these three books. There are so many books, excellent books. Please, you have to make use of all these things because it is going to be all case-based scenarios only. Not just these three books are general surgery. You have to come out of everything. You have to have open mind. So you have to read everything. Yeah. Thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified regarding my latest upload. Thank you once again for watching this video. Let us meet once again in the next video. Until then, bye-bye.